All right, good afternoon, everybody. Welcome to SEVA VentRounds. Today's March 8th, 2022, and the title of today's reading in order. And there are several examples that we're going to go over, and I think that they have good examples of why going in order is effective as going over the waveforms. The disclosure is we discuss particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. All are welcome. We love all of the ventilator modes. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic's opinion. I have conflicts of interest as well as Rob Chatburn that are listed down here for you to be aware of. The ground rules is this is recorded, so keep your microphone muted. I may call upon members of the audience to comment. Usually we're monitoring, both Rob and I are going over the chat function, so you can write whatever you want there, and that helps us know your thoughts and then call you as needed. And at the end, there's a CME. I know last time I had the wrong QR code. It has been updated to 2022. So if you are an employee of the Cleveland Clinic, please go ahead and go for it. Okay. So we start with a basic waveform on one of our patients. Anybody wants to read this from our fellows or RTs from the clinic on the line? Have no fear. The goal is to do as best as we can. Anybody?
I can do it.
All right.
Let me just mute the other one.
Okay, thank you, Marina.
Okay. It helps that you have pressure support CPAP at the top, so I'm super into that. I'm going to say pressure control. Every breath looks like it's triggered by the patient, so we're going to call it CSV. I am looking at the load now. The time constant doesn't look particularly prolonged, so I'm going to go elastic for both. Trigger is normal. I don't even know if you could do an abnormal trigger on a CSV setting, to be honest. I will ask you that later. You have a, I think, normal inspiration. Cycling is normal, but expiration, you look like you've got a little bit of expiratory work in the limb there. So I'm going to do that.
Okay, excellent, Marina. So let's go through it together. Indeed, you're absolutely right. This is pressure control. So meaning we're controlling the pressure during the breath. So you're excellent right there. You can see obviously the tag, the name over here, and because you're a frequent user of this mode, you immediately can say it. But let's just do it by the sake of it. So CSV stands for continuous spontaneous ventilation, meaning that all the breaths are triggered by the patient, and we have the pink marker here on this mode. On this ventilator, it turns pink. In others, they put arrows. In others, they put other markers elsewhere. But you know that this is triggered by the patient, and you could actually infer that too because of the drop on pressure over here before every single one of the breaths. And then all of the breaths are cycled by the patient, and we know that because of the tag that is over here. This patient is very regular. Actually, if you can see that the tidal volume doesn't change much, and sometimes that may create challenges in reading these waveforms because when patients lose their variability, like in this case, the eye time will look exactly the same under those circumstances. And I mean, it would be very hard for me, in the absence of seeing this over here, know what's cycling, but because I can see this being up here, I know that this is cycled by the patient, meaning at a given flow from the peak, because all the items are identical and the tidal volumes are also pretty similar. Okay, so and then the targeting scheme is called S, which is set point, meaning that you set all the variables. Essentially in this mode is the set inspiratory time. Very good.
Dr. Mireles, we've got a couple of guest learners. Can you mention how we know it's pressure?
Yeah, great. Guess, yes, thank you, Marina. So we know that this is pressure. Whenever looking at the ventilator, I like to look first at the flow waveform, just because if it has a geometrical shape, a triangle or a square, immediately you can tell that this is you're controlling the flow. However, it depends where the sensor is, and there's some nuances to that. But in general, that's the first place that I look. The second place that I look is within the flow to see if the flow has any of the characteristics of a descending ramp that you would see, or decelerating or exponential decay that comes with pressure control. So it should look like that, which we don't see. So it means that there's some patient effort, and then you see all the pressure has been controlled. So what means for pressure control means that during the breath, the machine is trying to keep the pressure at the set pressure that you gave the machine, and that's why it's doing so. So those are three of the clues that give you that this is pressure being controlled. In terms of the load, you have elastic, resistive, and PMOS, and this comes from the equation of motion. And the goal here is essentially, if you have PMOS, then you cannot tell what is the load. You know that the patient triggered here, and this doesn't decay, as I pointed out here, exponentially. So when it doesn't decay exponentially, it's really hard to tell what is the load, if it's elastic or resistive. And so all of this area over here is actually PMOS. So it's a little bit hard for me to say it, if that this is PMOS. This looks all as I cannot tell during inspiration if this is elastic. So I would say this is PMOS. And then during expiration, there is evidence of PMOS again. These little humps here are expiration, and actually, if there was no effort, no PMOS, no inspiratory PMOS, this should look probably something like that, if you can imagine it. So all this area over here is also PMOS. So you could, if you wanted, if you dare to do that, say, well, this is returning back to baseline relatively fast, and you can see that it's within 1.5 seconds or less. So elastic may be correct under these circumstances, even though the patient was doing effort. But I do see evidence of PMOS back there. So very good. I'll answer that in a second, Ariel. Thank you for putting that there. So in terms, so the majority of the effort, Marina, as you can see, is PMOS and some evidence of PMOS during expiration. Sorry, man, I'm gonna decline the request to annotate, because if not, you start writing on the screen. So any PV discordance, the trigger, you're right. It seems normal. I mean, you could make a case of saying, well, where did the actual effort start, and where did the machine trigger? But at least on this image, I cannot necessarily see. It seems that the change is right above when it crosses the flow. So I don't see any trigger issue. Your question is, can there be any abnormality on triggering? Yeah, and the answer is yes. There can be late trigger on pressure support if they set the sensitivity, the threshold too high, so the patient has to generate a lot of PMOS. You may see a late trigger. You may also see false triggers if there's oscillations from the heart. And you may also see failed triggers in patients in which you over-assist, meaning that the patient gets too much tidal volume for what they needed. They may want to take another breath as they are exhaling, and they will have a failed trigger under those circumstances. So early triggers should not occur under circumstances because the patient usually triggers the first breath. So normal, late, false, and failed, Marina, can occur. All right. In terms of inspiration, the answer is normal. I agree with you. There's this is one of those nuances in which you could say that there's work shifting, but it's what we would call normal. There's no deflections on the pressure waveform. It looks pretty good. So there's some work from the patient, no doubt. The patient is active. And then comes cycle, Marina. And this is the key finding here. As I have pointed out, all this shaded area is actually evidence of PMOS. So the patient, if you imagine his rest inspiratory effort, it would go all the way over here to here, and then it would relax, something like that. So this area over here is evidence that the ventilator cycled earlier and the patient was still doing effort. So this would be an early cycle in a patient with pressure support. And I'll ask, how would you fix it now that you know that this is an early cycle, meaning that the ventilator is cycling earlier than the patient? Would you change anything, Marina?
Yeah, you could. We're asking how to get rid of the early cycling. Is that correct? Sorry, we lost connection there for a second.
Yeah, that's so you would change the expiratory sensitivity. So the amount at which the peak flow cycles off the breath. So normally, I mean, a usual setting on a ventilator is that you would find it at 20 or 30%, meaning that from the inspiratory flow, from the peak, it will cycle when there's 20% of the peak flow. So you will, if the lower you move this number, let's say that you put 0, this would go all the way to 0, and then you would exhale. If you put 10%, it would be here, 20%, 30%, and so you can either even shorten it up if you want it. But in this case, you would prolong it so that the patient continues to receive flow all the way to here, and the ventilator continues to support the PMOS, if that is aligned with the patient.
How do you know it's early cycling and not active expiratory effort?
So remember that whatever moves towards the baseline when you're exhaling or below this means that the patient is doing inspiratory effort. If it's moving away, that is expiratory effort. So when you talk about expiratory work, what you would expect to see is this actually moving like that, away from the expected exponential decay. So that would be expiratory work.
That makes sense.
Very good. And so in terms of expiratory work, maybe a little bit of activity, but I would call it more than anything normal. So in summary, this is pressure control CSB with spontaneous breaths. There you see evidence of activity during inspiration. The trigger is normal. The inspiration seems to be normal with a little bit of work shifting or some amount of work shifting. And the cycle is early. And the way to change that would be to change your expiratory cycle off value. And then in terms of expiration, it's essentially normal normal expiration. So let's go over the feelings here. There's a lot of comments, so thank you. Ariel says PCCSB with early cycling and evidence of pre-MOS. Very good, Ariel. Excellent. He says TIs are slightly different. I guess so. But it's not easily discernible. There is a little step at the end of the tidal volume exhale just before the beginning of the next breath, but the flow seems to reach the baseline. And so he comments, could this be a small leak? It could be. it certainly can occur that these small discrepancies are the presence of a inspiratory or expiratory leak. Good either. AN says, is exhalation PMOS or early cycling? The early cycling, as we commented, if patient is working during expiration, means there is resistance in the circuit airways. So doesn't expiratory work shifting automatically mean that there is some resistive load? Well, it could be, and it couldn't be. I mean, Udi, that's a great question. It depends on the etiology of the expiratory work. As you can imagine, a patient with active severe metabolic acidosis or increased work of breathing from pain, anxiety, delirium, whatnot, may have an active expiratory expiration without the presence of a resistive load. Ibrahim says, drop the inspiratory cycle, decrease the percent, and end expiratory cycle off. So actually, this is a good point. You can see on the three comments how they use different terms to describe the setting on the ventilator, and it all depends on the machine that you use. All of them use different values, and it's really crazy when you're trying to do this, because there's some that talk about inspiratory cycle percent, others that say end expiratory percent, others say ETS or end trigger threshold or whatever. I mean, it changes throughout the literature and the manufacturers, so just be aware about that. Yeah, so that's right, Ibrahim. Some ventilators may not allow you to change that. I'm trying to think which one would do that. So I don't know which one, but some ventilators may have different settings. I mean, recently when we got the Hamiltons, we one of the comments was, well, you cannot set a pressure trigger on these machines, and it turned out that you could. It just was hidden in the background, and you have to activate it so that it's present for the caregivers to use it, if you think that that is something that is useful for the caregivers. Very good. Excellent comments. All right, I have the next one. Anybody wants to read this from our RTs or fellows? Any of our fellows wants to jump up? And this one was submitted by one of our fellows in-house, so it's actually pretty cool.
Mike Smith is volunteering. I'm gonna hand this over.
No, I cannot be Mike Smith.
Oh, just kidding. Then it can't be Mike Smith. Does anybody else here want to do it?
Mike submitted it, so he knows what's going on. Mike, you get the next one. Anybody else? And don't put sad face, Mike. Come on.
I can try to redeem myself. How about that?
No, Marina, you did one. Come on. There's has to be.
Good, Eadi here.
Okay, Eadi. Go for it.
So tag will be PCCMV. I'm gonna say S. Load, looking at the flow waveform. Yeah, I think it's elastic. I'm gonna go with elastic, and the inspiratory load. Think that there'll be some PMOS in the expiratory limb, elastic plus expiratory. I don't see any resistive loads. Let's go by trigger wise. First breath, triggers seem to be normal, but I'm trying to see in the third breath what's happening, because it's going down. The flow is going down to the baseline, and then there is still a negative deflection, which means the patient's breathing out. Okay, and then the patient takes a big breath. So if the patient's still breathing out, means the patient is still exhaling. And there's also a positive pressure deflection on the pressure waveform. Yeah, so it is deflecting. It's not playing a trick on me. So yeah, I think your trigger should seem to be normal. I don't see a delay or anything. I would say this is normal. Inspiration.
So you said normal
very
trigger?
slow there. Yeah, I think so. Yeah.
Okay.
Wait, make me rethink this. Yeah, when the patient's neural time. Yeah, when the patient has a planning to take a breath, I think it's responding appropriately as far as I can make out. Inspiration, I think that there is some work shifting, as you can see with the deflections in the flow waveform. Cycle. Breathe. Cycle. I would say cycle seems to be normal. Expiratory, I think there is expiratory work.
Thank you, Eadi. Marina, do you agree with Eadi? No, Marina. All right, Marina. Digo, Eadi, here we go. Oh, there's Marina. Okay. Thank you, Marina. So pressure control again. The breath, the pressure, the machine is controlling pressure during inspiration. So Eadi, you're absolutely correct. It's CMB. I mean, you can see the name of the mode up here, but essentially, even though it's patient triggered, if the patient would stop breathing, the machine would trigger the breath. So it can be either patient or machine trigger under this mode.
Your audio
What's up, Eadi?
cutting off.
Eadi?
Me or
I think Eadi is talking to somebody else. Eadi? Okay, let me mute him. Okay, he's muted now. Very good. So where were we? CMB, so mandatory because all breaths are terminated by the machine. And in these circumstances, all the I times actually look the same, and we have the tag up top. And it's set point, and we cannot determine that just by looking at the waveforms. But in this case, all the pressure has remained the same, and there's no variations, which tells us that this is an inspiratory time that has been set, an inspiratory pressure that has been set. Uri talked about an elastic load, and certainly during inspiration, it's hard for me to see. It doesn't reach the end of the breath, so there's the cycle is occurring. I mean, it's set before it reaches zero, but you certainly can see that there's not really any PMOS or clear PMOS afterwards. Perhaps a little bit, but I'm not entirely clear there. And then during expiration, it doesn't decay. I mean, you would expect this to decay something like that. It doesn't, which makes you think that there's some expiratory work, and I would have to tend to agree with Eadi unless there's something else that I'm missing. But it looks like the patient is doing some effort to inhale and some effort to exhale, at least from this waveform. That's how I would have read it. In terms of trigger, it seems that all breaths are being triggered except these two that are here. There's one here and there's one here that several of you, Tim, CR, recognized these two, as well as Ariel. So there are a number of failed triggers here just by the way that the waveform looks. In terms of the cycle, you could probably make an argument that it's normal if you consider that there's not much PMOS in here. I don't think this is a delayed trigger or a trigger delay or late trigger. That's how we would call it. I mean, the breath is starting immediately here, and there's no evidence of any deformation on the PMOS on the pressure waveform. So it's hard for me to see anything, and so these episodes over here are missed or failed triggers. And then as Udi read this, I would have read this as expiratory work. However, it seems that we were fooled by this. So these are definitely missed triggers. Mike, since you're on the line, you're the one that sent me these waveforms. Do you want to tell us what was happening with the patient before I show the next waveform that you sent me?
Yeah, of course. So this is one that I sat in front of this patient's bed for a while and was trying to figure out why this was going on. I think the only addendums that I would have to this is that my sense is that this was actually both early trigger and early cycle. And this is kind of what I interpreted based. If you look at the flow waveform, it initially starts to decrease pretty quickly, and then afterwards starts to pick up from PMOS. And you can kind of see in the pressure waveform as well. Initially, it pressurizes pretty good, and then you start to see a negative deflection in the pressure waveform. And so this was somebody who is a liver patient, was in septic shock, very hyperdynamic hearts. And so what we were seeing here was actually that his cardiac oscillations were triggering the vent early, and he was still active on the ventilator, still with the ventilator, but he was essentially his own respiratory cycle was being triggered by the ventilator auto triggering from cardiac oscillations. And I guess you can see that on the next. You can see that on the next waveform that I'm hoping you're going to show here.
Yeah. So a key thing just to so if this is a patient triggered breath, this could not be an early trigger because it was triggered by the patient. Does that make sense, Mike? So
I guess
remember
I'm having a hard time differentiating what would be a patient trigger versus like the auto trigger, since both of them the ventilator would interpret as being given to you from the patient.
exactly. So that's the key here. So you would have you cannot make that difference from looking at this waveform of what is a false trigger and what is not. And I'll show the next waveform in a second. But just from the taxonomy standpoint, an early trigger, which has many different causes, and this is could be a different one, it's a mandatory breath with evidence of PMOS during inspiration or early expiration. So that's one. So this could not be because it's not a machine trigger; it's a patient trigger. Does that make sense? Just from taxonomy standpoint. So when you're classifying this, and then you could say, well, actually, it turns out that this is a false trigger and or a failed trigger, and we can argue about those things. So if you let's take a look at this other waveform that you have over here. Oh, and the other thing that I would say is this oscillation over here that you have here, that you have throughout every breath, it's probably what's giving you this little regular notch up here, which is consistent, and the same with this one over here that you see over here. So these are artifacts from pressurization and depressurization. So this is an artifact, and the changes in pressure leads to changes in flow that you see over here and you see over here, if that makes sense.
Dr.
So
Manuel,
let's take, yes.
so just to go back to the screen, that if that is in the third breath, if that is a failed trigger, how come there's a positive deflection in the pressure wave? Because a trigger would accompany be a negative pressure deflection.
Yeah, great questions. So actually, what you usually will see, and it depends on the gain and the ability to adjust your screen, is you're gonna see actually a negative deflection, which is what you see from right there, and then followed by a positive deflection. So you see that over here because the airway is oscillating, Udi. So there's the negative, and then there's the positive. It relaxes, and so you're gonna see the pressure go up because the machine is trying to maintain the pressure stable. Does that make sense?
Yeah, thanks.
Okay. So and actually you can see it here. This I mean, this is a beautiful waveform from Mike, in which I presume that he changed the trigger to pressure. Is that what you do, Mike? Was that a yes? I cannot hear.
Yes.
Yes. Okay. Thank you, Marina. And now you have the rate that they had on the ventilator, which was 12. And so now you see these breaths actually, and just compare this breath that is over here, in which it's not patient triggered, it's actually machine trigger. I think this may, no, it's not machine trigger. It's this is machine, this is machine. Both are machine triggered. So look at them. Do you see a difference between them? They look exactly the same, right? So I don't know if this patient was alkalotic at that time, but that's what you.
So yes, he was. His pH
Yeah.
was around 7.5 to 7.53 or so. And like I said, I have a little more information here, which is that he was completely and totally apneic. He has absolutely zero respiratory effort at bedside.
Excellent. And that's why it's great that you're here, Mike, to tell us that. So this is the waveform that you're seeing doesn't demonstrate any PMOS. It's just the aberrancies that are coming from the flow that this patient is having, and actually this is a very good example of that. And you can see the down trend and up, down, up, down, up that you see over here, down and up oscillations that were generating enough flow to trigger the breath. And so you could abolish that by changing to pressure. You would have to generate enough negative pressure to achieve that, or you can just increase the flow threshold so that it's higher and it doesn't trigger the breath. And now you can actually read this waveform a little bit better. You can see that here, and that definitely looks elastic in nature. It goes back to baseline immediately. So, and you could potentially make the case just by looking at this, the amount of inspiratory pressure this patient required to deliver the tidal volume that he has, and you have the compliance over here. Very good. Excellent, Uri. So there is there's also the dog ear overshoot is due to the low IRT in the setting of increased elastic load. So I presume that you talk about this overshoot, Ibrahim, and indeed, this is a manifestation of the pressurization. So the machine pressurizes, and then you have this oscillation, and it's part of the inspiratory the rise time, inspiratory rise time, and you may have the oscillation, which means nothing, and it doesn't cause any injury in general to the airway or the lung. Make an expiratory pause and see what is the patient effort. Yeah, that's a good strategy too. You could create an expiratory pause by just pressing the button here on maneuvers, and that would generate a pause, and you could see if there's any effort, patient actual effort, you will see a drop in the inspiratory pressure in those patients. Ariel says, I suspect auto-triggering, so false triggering, when an unexplained respiratory acidosis is present that does not match the sedation status. It would be alkalosis, actually, that the patient has respiratory alkalosis because the CO2 goes down and it doesn't match sedation. The other item, I mean, this is a common thing for us, is the patient, he continues to breathe above the vent, and then they paralyze him, and the patient continues to do so. I mean, there's whenever you suspect that there is paralytic failure, you should suspect that there is waveform failure. That there's a false trigger that we are unable to see or suspect. And so just be aware of that. Excellent. Excellent job. Great job, Marina. Great job, Udi, reading this. Thank you, Mike, for sharing this case. I mean, I would not have picked it up. I can tell you that. This was very, very interesting.
A quick question, Dr. Mireles, on the second waveform.
Yes, Ahmed.
from a taxonomy standpoint, now that in this waveform it is very clear these are cardiac oscillation, but the waveform is crossing the baseline. Would you call or would you not call this field trigger from a taxonomy standpoint? We know what's happening.
Yeah,
Because
this
it's
would be,
crossing, but it's not triggering. So
yeah, so this becomes immediately, thank you very much for saying, this is a false trigger, right? From the taxonomy.
so you'd label it as false trigger, and you would not say field trigger because you know there is not a true patient effort.
Exactly. So this is a case of false trigger mimicking a failed trigger and in a human being. Sabotage.
So, Dr. Mireles, now that that's been addressed on the second waveform, the trigger is now normal, right?
Yes. Well, the trigger right now is mechanical, right? So
Right. There's no trigger.
right, exactly. Great question. Very good. So just to summarize, in this case, it's still PC, CMB is it is the load is elastic, and we know that just by looking at the time that it takes to get back to baseline, and you also can see the amount of pressure this individual is having. The trigger is false trigger. From there, there's actually no evidence of PMOS otherwise. So this patient doesn't have anything else except the false trigger or the false trigger that was clinically discovered by alkalosis and a keen, thoughtful fellow at the bedside. So great job. Phew. All right. I put another one. This one looks a little bit odd, but just bear with me. It's just what I can do. So anybody wants to read this one? Come on, any of our fellows or RTs? Anybody?
This is Mohammed. I can try. Sorry.
There you go, Mohammed. Go for it.
So can I just ask, is there another waveform on top of the pressure waveform that we don't have access to yet?
Yeah.
Okay.
So don't cheat.
Okay. So just from looking at this, it looks like pressure control. The I times look similar. I don't see any triggers, but the delivered volume is different. So I don't know if that makes it like PCCMVA, like there's an adaptive component to it. I also wonder if the other waveform is like a neural waveform, and this is like a NAVA setting, which would make it a PCCMVS. In terms of load, it looks pretty elastic on inspiration. I'm trying to decide if I want to commit to PMOS or not. I think elastic for now while I think about it. PV discordance. If I'm saying that the triggers are all machine triggered, then there's no problem with the trigger. But if I look at the blue waveform as like a neural waveform, then perhaps there's like the third breath is
I'm gonna help you. There is forget about NAVA.
Okay. So then the trigger becomes normal. There's perhaps on the third breath some inspiration work shifting, that like scoop in thing. The cycle seems late. There's like this pause in the first and second before exhalation. And then expiratory wise, I guess on the third breath, there's expiratory work. I don't know. I feel like I royally messed this up, but that's my best effort.
This one is a hard one, my friend. So I'm gonna help you through it. But I really appreciate because you have a keen eye for detail, and that's what counts. So let me organize you a little bit. So without a doubt, this is pressure control, and the features that you have here is that the volume is not controlled through it, and there's this pause at the end, and there's the pressure seems to be controlled throughout the breath. So I completely agree with you. This is CMB, and it becomes CMB rapidly, just for you to know it. Just whenever you see a pause at the end of the breath, immediately it becomes a mandatory breath. Just because that means that the patient was trying to exhale, and we're not letting the patient exhale because there's the I time is set, either an expiratory pause at the end, which means that the patient is not controlling expiration, and that makes it a mandatory breath. And finally, in terms of the pressure, it's hard to see it here, but there doesn't seem to be, or maybe there's some change in the pressure. We'll take a look at the next waveform, and you're gonna know where we are. So it's hard for me to completely define it. So it could be adaptive, it could be set point, but it's definitely not NAVA. And we'll talk about that in a second. In terms of the load, remember always how your waveform should look whenever the patient is passive, and it has to have a decay, and usually it has to be an exponential decay. This patient, as you identified, seems to have a very low elastance, and you know that this is a mandatory breath. There's no change in color on the here. Actually, you can see the drop in pressure for the breath. There's none here. There's none here. There's no change. There's no change. So this makes me think that this is a passive breath, and makes me consistent with elastic load, as you read it. And the return back to baseline seems relatively fast for all of the breaths. So I will live with that. Although there is evidence of PMOS on other breaths. There is evidence of PMOS here. And actually, this one is probably a change in PMOS. You can see how there's a change in the flow, and this doesn't decay exponentially. So that makes me think that this is presence of PMOS during inspiration, but probably with an increased elastic load. Now comes the trigger, and the trigger is the tricky one here. So you just have one breath that seems to have been triggered by, and this is not the best waveform ever, and you're like, Eduardo, I hate you, and so that's okay. But there is one over here that it's a classic one, and you see no evidence of PMOS, so this is a mandatory breath, and then suddenly you see evidence of PMOS afterwards, and that's called an early trigger, meaning the machine triggered earlier than the patient. And some people call it reverse trigger, although that refers to a specific phenomenon that occurs in patients, and not necessarily here. So there's some work shifting, as you pointed out, here and here. So I'm aligned with you. It's not terrible. It doesn't drop the pressure below baseline. And there's late cycle, that's very good. You recognize that here. And finally, look at the expiration on this one. So because there's reverse trigger, the patient was doing PMOS, and here you can see that the breath ended, and the patient was still trying to get air in, and the ventilator would just not allow that. So the patient was doing the effort in, it didn't trigger another breath under these circumstances, and then the patient starts exhaling. So The key here is, and why I like this waveform is because we had the patient, actually, we placed, this was one of the early COVID patients that we had, and we were fighting with the patient to try to get him to coordinate with the ventilator. And the message here was that the mode was, you can see that it's pressure control, CMBS, as you were suspecting. And then you have here that waveform that you rapidly recognized, which is over here, and that's an overlay of the EDI signal, which is down here, this pink waveform. So this is the electrical activity of the diaphragm in millivolts. And this patient was having, as you can see, very high respiratory effort. So the EDI is even above 20. I think it was 35 on the patient. But what it allows us to see is actually the type of desynchrony that it's occurring on the individual. And I really like this one because it helps. So do remember that when you are on pressure control, you look at the flow waveform. So if you're on pressure control, I come and look at the flow waveform for those interactions. And so let's just go over this and go over each one of the waveforms. So we have trigger, inspiration, cycle, and expiration. And let's start with the first waveform over here that you can see. You can see the EDI. So there's activity of the diaphragm all the way over here. And here is where the breath ends. So right here is where the breath ends. They put the cycle criteria lower, but that's where it peaks and then it relaxes. And you can see actually here the evidence of an early cycle or PMOS activity, the patient inhaling, generating an active EDI, and all of this area right here is evidence of PMOS. Now, we don't know what's happening before this, but that would be evidence of PMOS. Then you can see the patient relaxes very nicely. There's no evidence of PMOS. Then the machine triggers a breath, and you can see there's absolutely no PMOS. So this is a passive breath over here. This is a completely passive breath with a cycle that it's, I mean, in this case, it would not even be a late cycle because there's no PMOS. It didn't trigger anything, but it's the way that you set the machine. But on the next breath, it actually does trigger the breath. So you can see how it triggers. It triggers the flow goes up, triggers the pressurization of the machine. And here is where the breath cycles. And if you go down, I mean, with my low quality, the PMOS ends and the patient, so this would be definitely an early or late, sorry, late cycle. And we know now that because of this, and we actually could see it before, that's how we read it. Then the patient relaxes, there's no activity. And then comes the next breath in which you can actually see up here, there's no actual activity of the muscle. The breath gets triggered by the machine. It pressurizes, and actually a clue for that is you can see the height of this flow is actually pretty similar to the height of this flow, which tells you that this is a passive breath, started passive on this patient. And then the early trigger occurs. So the ventilator triggered early, then the patient did, so it's an early trigger. The patient starts pressurizing, and as the patient generates pressure, there is this bimodal EDI, which is actually a known cause of double trigger in NABA, but we're not going to get in there. And then it finishes and cycles all the way over here, which ends up with the breath, and then the patient exhales. So this is a nice cause of early trigger, late cycle, and inspiratory work, or a missed trigger right here for this patient, which should tell you how much. Sometimes, I mean, the waveforms can tell you a lot, but the EDI certainly adds another dimension. And as you know, we have that available at the unit, and you can use it sometimes just to monitor and to try to figure out what's happening with the patient. All righty. questions? I'm gonna go down the chat. There's a lot of comments. So Ariel read it as we just did. It's not late triggering. It's early trigger and the late cycling. I'm gonna guess EDI is only being monitored here by the vent, but not being utilized for NAVA. That's correct, Aman. This was just placed, and actually we tried the patient on NAVA. The key here to know, Mohammed, you mentioned that how do I know this is not NAVA? Usually what you're gonna see is that the waveform for pressure, because it's proportional, will actually mimic the pressure for the EDI. So it will look exactly like this one. It would look like that one, and it would look like that, your pressure waveform, and then it would cycle off. The higher the peak inspiratory flow is, the higher the inspiratory muscle is. That's correct. It's a nice way to observe the drive. Should we decrease the respiratory rate to match the... So yeah, so that's now that we know more about how reverse trigger can be managed or adjusted. I think that the common practice for all of us is to decrease the rate and see what happens to the patient. And if that doesn't do it, then obviously it's also a sign in my mind of toxicity of the sedation. It's affecting the most basic respiratory centers to have these reflexes that are relatively primary. So avoiding that would be, if possible, the best thing ever.
Hey, this is Tim from Indian River, and I'm not familiar with the EADI waveform. I've never seen it. Can you explain it?
Yeah, absolutely, Tim. Thank you for asking. So the way that this works is we have the patient, and we introduce through the nose usually, but it can also go through the mouth. You introduce a catheter all the way down into the esophagus and into the stomach. And it's a special type of catheter, and that catheter has a area where you can connect, and it has sensors throughout, several sensors through the catheter and you calculate that. There's a formula to calculate where you're going to put it. And then what it does, this catheter, is the diaphragm is going through here like that. Actually, the crew of the diaphragm, which the crura is where it meets and anchors itself to the thoracic spine and lumbar spine, and so it attaches to it, and the catheter goes through the hole with the esophagus, and so it can measure the activation, the EMG of the diaphragm. So normally the EMG of the diaphragm will look something like that, and this is adding up all the waveforms. Actually, I do invite you to read the chapter by Cinderby in the Tobin's book. It has a very nice explanation of how they came up to generate this waveform. And so the activity, so it adds this waveform, and what they did is, instead of showing this very dirty or raw image, is they use a mathematical transformation to generate a waveform that represents the activity of all this noise or signals from the EMG. And that waveform then gets presented in the ventilator as this smoothed out nice waveform, and so which looks like this. I didn't adjust the gain at that time, and I should be slapped for not doing that. It was low quality picture. But you can see over here, it overlays by the program on top of the pressure waveform for this ventilator, and so that's what you see on top of it. And it's measured in millivolts, which you see over here. And actually, you will, whenever you see a patient with this catheter, this representation that you see over here is the catheter, and these are the sensors that are detecting the image on the diaphragm. I hope that helps.
Yeah, thank you so much. Wow.
Quick question, Dr. Mireles. In the second breath, we see that based on the EDI waveform, there is no patient activity. But when you look at the
Yes.
flow waveform, it is not a passive decelerating or like a passive decay. Why?
Yeah, that's a great question. I love it. So there's multiple reasons for this, and one of them is one of the limitations of the EDI may be the presence of other muscle activity in the that you're not detecting during the EDI. So esophageal pressure may be better under those circumstances because you may detect other electrical activities of the diaphragm that you could then potentially see. uh, that's what I could ascertain to this case is the activity of other muscles leading to aberrations on the waveform that you're seeing over here. That could be one. The other one is that simply not the compliance of the lung or compliances of the lung were not as homogeneous as we want, and we may have others activating there. But this was eye-opening for me because I would have read as Mohammed did this as PMOS. So that's why I put this here.
Thank you.
No problem. So I'm gonna put there the code, the CME code. Here's the code, and here's the QR code. Just scan it and put in the code, and you'll get your CMEs. And again, here's just send us your waveforms. All the fellows really, I really appreciate it. This is a really interesting series of curves that we got. I applaud Mike for catching that. Thank you very much, Marina, for jumping in and reading that waveform. That's how we learn. And the same for Mohammed and Eadi. You guys are rocking and moving and learning even more day after day. So thank you very much, and have a great day.